Good afternoon and welcome to the Medical Education panel of the first annual Eastern Medical Research Conference, organized by AFMR Eastern's very own Chair-elect Andrea Hahn. Our topic today will be Recognizing and Disrupting Microaggressions. I am Laura Castleman, AFMR Eastern Chair. I would like to start by introducing our panelists, Peter Asante, Abena Knight, Donna de Leovonte Raphael, and Orla O'Donoghue. Dr. Asante is a general pediatrician, medical director of the Teen Health Clinic at Yakima Pediatrics, Community Health of Central Washington, and chair of pediatrics at Yakima Valley Memorial Hospital in Yakima, Washington. Dr. Knight is Associate Vice Chair of Education, Associate Clerkship Director of Inpatient Pediatrics, and Clinical Associate Professor of Pediatrics at the University of Washington School of Medicine, Seattle Children's Hospital in Seattle, Washington. Dr. Leovonte Raphael is the Director of National Memory Screening Program at the Alzheimer's Foundation of America. She has over 12 years of experience in developing and implementing and managing meaningful high-impact programs that improve quality, relevance, and sustainability of diverse and inclusive initiatives. Dr. O'Donoghue received her PhD in neuroscience from University College Cork, Ireland. She is Director of Problem-Based Learning and Director of Neuroanatomical Sciences at NYU Long Island School of Medicine in New York. She has an immense interest in active learning and medical education research. She has taught over 10,000 medical students across the world in multiple venues, from cruise ships to hotels to in the dark. Thank you to all the panelists for your willingness to participate in our medical education session. Finally, it is my pleasure to introduce our speakers today, Lanre Feluci and Enrique Escalante. Dr. Feluci is Associate Program Director of the Pediatric Residency Program at Children's National Hospital, Director of the Leadership and Advocacy, Under-Resourced Communities, and Health Equity Launch Track, and Assistant Professor of Pediatrics at George Washington University School of Medicine and Health Sciences in Washington, D.C. Dr. Escalante is Assistant Program Director of Diversity, Equity, and Inclusion for the Pediatric Residency Program at Children's National Hospital, and Assistant Professor of Pediatrics at George Washington University School of Medicine and Health Sciences in Washington, D.C. If you have questions for the presenters, you may ask them by typing into the Zoom Q&A area. I will now turn this over to our first speaker, Dr. Enrique Escalante.
You're muted, Dr. Escalante.
Wonderful. Are you guys able to see my slides? Wonderful. Awesome. Thank you very much for having us. We really appreciate it. So for this session, we're going to be talking about recognizing and disrupting microaggressions. So Dr. Feluci and I thank you very much for letting us talk with you a little bit, and then towards the end, we're going to have a panel discussion. So I'm going to start off with a question for the audience. Hopefully we can get the polls working here. But the question, if we can see the polls, if not, we might just go ahead and jump through it. There we go. Could you answer, I guess we'll go through them all. So the first question really is, how familiar are you with the terms implicit bias and microaggressions? And we'd love the audience to fill out those question. And when we have enough responses, we can see the answer to that one, just to get a sense of who's in the audience for today. Are we able to see the responses at this point? All right, wonderful. So in terms of folks who are, the first question, how familiar are you with the terms implicit bias and microaggression? So about a little over 60% are familiar, and then the rest being either somewhat familiar or not familiar. In terms of folks who have witnessed microaggressions, about a large chunk of us have. And there's 20% of folks responded, I don't know, which is a very fair and valid point, and we'll try to cover why that's the case. Have you ever been the target of microaggressions? So about 3/4 yes, little bit, a few of us know, and then the rest I don't know. So thank you for that. And then the last one is, have you ever addressed microaggressions? And about 50% have, 50% haven't, so a little bit more in the group that has than the group that hasn't. But thank you for that. So we'll sort of keep going. So the objectives for today or for this talk are really simple. It's really to identify how implicit bias and microaggressions impact clinical and learning environment, recognize how to address biases on an interpersonal and systemic level, and then construct a plan to disrupt bias and promote equity. So just to lay the groundwork, it sounds like most folks are familiar with these terms, but just to lay the groundwork, implicit unconscious bias, we all have them. The point of acknowledging that is it's the first step in moving forward. We all have them. The question is really, what do we do with them in order to make our work environments productive? Hopefully you've all heard about the implicit association test, or Project Implicit, where users are asked to match an image with a category of people. And in this example, it's Black or white people. Another example would be older, young people, gay people, straight people, abled persons, disabled persons. And through this matching, we sort of are able to identify where our implicit biases lie. But the implicit biases are a result of our cultural conditioning, and often biases are contrary to our personal values. So someone may say, I don't have any ill feelings towards disabled persons, as in this example, but through this implicit association test, we may see that that is not always the case. So personally mediated or interpersonal racism involves discrimination. It assumes different abilities, motives, intentions by race. It's intentional or unintentional, and it's explicit or implicit. And there can be either overt racist actions or microaggressions. Obviously, we have all, over the last few years, really sort of focused on systemic racism, which is extremely prevalent in our society, but we're really going to focus on is microaggressions. So what are microaggressions? So microaggressions are brief and commonplace verbal, behavioral, and environmental indignities, whether intentional or unintentional, that can communicate hostile, derogatory, or negative slights and insults that potentially have harmful or unpleasant psychological impact on the target person or group. Microaggressions can be based off of race, income, social capital, religion, ableness, gender, immigration status, sexual orientation, or any other host of characteristics. There are three types of microaggressions. There are three main types. There's microassault, and microassaults are the explicit racial derogation characterized by verbal or nonverbal attack meant to hurt the victim through name calling, avoidant behavior, or purposeful discriminatory behavior. It's usually conscious and deliberate. Micro insults, which convey rudeness or insensitivity, they demean a person's identity. They represent subtle snubs frequently unknown to the perpetrator. And microinvalidation are communications that exclude, negate, or nullify psychological thoughts and feelings. So some of you might be thinking, that doesn't quite make sense, or can you give me an example of microinvalidation? One that we commonly see in our day-to-day lives is when we express discomfort with something and the person that we're talking to says, don't worry about it. Don't be so sensitive. You're thinking about it too much, and things like that. So we'll skip these questions since we already answered them all. So the next step is really sort of discussing why is it so hard to address microaggressions. So there's really 5 dilemmas that I'm going to run through at the beginning of this talk. So dilemma 1 is the perceived minimal harm of microaggressions. There's no acknowledgement of cumulative effects. So this is an example that is used pretty frequently, which is a mosquito bite. So if I get one mosquito bite, it doesn't really bother me that much. I scratch it a little bit and then forget about it. But if I'm constantly bitten by a mosquito or constantly the target of microaggressions, it really starts to take a toll on my mental and emotional well-being. Dilemma number 2, which is the clash of realities. Most people think of themselves as good, moral human beings. This makes it hard for them to believe that they possess biased attitudes and engage in behaviors that are discriminatory or hurtful. The perpetrator in these microaggressions views the intent, so I didn't mean to hurt anybody, whereas the recipient always views the impact. Regardless of what the perpetrator meant, I felt invalidated. Dilemma number 3, the invisibility or unintentional expression of bias. So it's hard to identify a microaggression where there are other explanations that could be plausible. Microaggressions rarely have a negative intent. Dilemma number 4, catch-22. This is when we think about when we think we saw a microaggression, we may end up thinking about all of these questions. Did what I think happened really happen? Was this a deliberate act or was it unintentional? How should I respond? Do I sit and stew on it or do I confront the person? If I bring up the topic, how do I prove it? Is it really worth the effort to fight about this or to bring it up? Should I just drop the matter? So trying to balance all of that also has an emotional or plays an emotional toll on our well-being. And the last one is dilemma number 5, which is calling people out can be awkward. It's sometimes difficult to bring this up with a coworker or a family member, and finding the right way to deliver that message can be difficult if we haven't done it before. There's also power gradients at play. But now let's sort of move on to why it's important to address these microaggressions. So it's important to emphasize that microaggressions are not about having hurt feelings. Rather, it's about the negative effect of being repeatedly insulted, invalidated, alienated, or dismissed that have at both a micro and a macro social level. Microaggressions have a very specific impact on our trainees. They diminish an individual's ability to fully participate in complex cognitive tasks, which is really what our trainees are really starting to learn to do, to take care of people in very complex situations. So if they're also having to focus on microaggressions or other difficulties, this can lead to difficulty in their learning environment. They lead to negative and emotional and physical repercussions, decreased work performance, and ethical distress. And they also have a larger potential to have a larger negative impact when it occurs early in a physician's career than later on. And I'm not saying that it doesn't have a negative effect in the more seasoned folks, but in folks who are just starting their training, there is a larger potential to have a negative impact on the career. So I'm going to now hand it over to Dr. Feluci.
Thank you, Dr. Escalante. So what role do you play when it comes to microaggressions, racism, or discrimination? There we go. Okay, a little bit of a delay. We don't want to be the offender, right? No one really, or few people, I should say, really aim to be the perpetrator. I think most of us are trying to learn and to do better, and don't have it as our aim to be the offender in these situations. You also don't want to be the target or the recipient, as Dr. Escalante mentioned. That can be harmful both on a biological level and certainly on a greater social level. You also don't want to be bystanders, even though that is often where we end up. And a bystander, of course, being an individual who witnesses a situation of interest, but does not necessarily act as they witness it. So kind of standing by and being a witness to this. So there is hopefully one other role that we are aiming for, right? Not to be the offender nor the target, and really wanting to be more active than a bystander. And this is where we get into moving from bystanding to now disrupting racism. So if we talk about racism in particular, very well may be that there's a lack of understanding of what racism even looks like. So oftentimes it goes unnoticed. And even if it is noticed, people may find themselves bystanding because they don't want to lose friendships or embarrass their colleagues or lose their privacy or to be retaliated against. So bystanders end up maintaining the oppression because of the weight of the cost of standing up, and may become intentionally or more often unintentionally complicit in maintaining the oppression of a group. What are some of the alternatives? You've probably heard the term ally, right? So an ally is someone who is by your side in terms of sharing the same values around diversity, equity, and inclusion. But going a step further, a co-conspirator or an accomplice, they may act. They're willing to publicly take a risk and feel like they may stand to lose something alongside those who are acting against racism. So actually putting their neck out a little bit. So this is why we really encourage that we move towards becoming disruptors, because we want to get to a point where being a co-conspirator or an accomplice is not a risk, where we're in an environment where anti-racism is a social norm where lack of discrimination of any of those demographics that Dr. Escalante mentioned, we want that to be the social norm, that we don't have those levels of discrimination. So disruptors are working to disrupt those social norms, again, calling out inequities so we get to the point where calling out inequities no longer feels like a risk. So we'll talk about disrupting in 3 different ways: how we can disrupt in the moment, how we can disrupt in our teaching as educators, and how we can disrupt on a systemic level. In the moment can be really tough. Dr. Escalante mentioned 5 different reasons why people may shy away from speaking up around microaggressions, and there may be a list of 20 other reasons that you all can come up with. So we wanted to make sure that we gave you the tools so that in the moment, as you are witnessing these events occur, that you're not just bystanding, but actually acting towards disrupting. I think one of my favorites is asking for clarification. So when someone in a meeting or on rounds or in a social setting says something that just doesn't quite sit right with you, whether it's around race or gender or another issue, I think asking for clarification is rarely the wrong thing to do. It gives you a moment to maybe put your thoughts together. And I think what it does too is it causes the other person to rethink that comment that they made. Again, I think we can give most people the benefit of the doubt, right? We're all kind of socialized in an environment where we learn subconsciously that there are hierarchies around certain demographics. So people are often talking and speaking out of those implicit biases, but we can call that out in a way that hopefully causes some self-reflection on the speaker. So things like, could you say more about what you mean by that? Or, I think I hear you say that XYZ, is that what you meant? So giving, again, that person a moment to kind of reflect upon what they said or wrote and to maybe think twice. Another way to disrupt bias in the moment is to ask about their process. So when someone speaks, how have you come to think that? So whether it's a generalization around a type of person, or maybe a misunderstanding around health disparities. How did you come to that conclusion? And having people again kind of reflect upon where those biases may be based on. And then finally, sharing your own process. I think this can be very powerful, particularly if you can relate to the other person based on similar upbringing or whatever it may be. I noticed that you said this thing about this group of people. I used to say that too. I used to think that too, but then I learned that such and such, right? So by this way, you're not specifically confronting their behavior, more so sharing your own thought process, your own evolution and your thinking around whatever the issue might be. Then secondly, as teachers, as faculty, as educators, we have a real responsibility to teach our trainees around anti-racism and disrupting other forms of bias. Some very hopefully practical ways to do this. First, we encourage you to prompt your trainees to think about how their own implicit bias and how systemic biases may be operating in a situation. So for example, constantly reminding trainees that race is a social construct and that racism, not race, is a social determinant of health. We've all sat through lectures around a particular illness, and there goes the chart, right, that lists what the prevalence of that illness is based on different demographics. So not just stopping there, but saying, let's talk about why it is that this group of people is disproportionately represented in this illness. Let's talk about healthcare access or education and discussing kind of the history of how we end up having these disparities. And hopefully in that way, we're disrupting the idea that, the amount of melanin in one's skin is a determinant of health. Secondly, describe the racial health disparities in the topic. So if you're lecturing on abdominal pain, for example, you can teach on the historical and current disparities in pain management based on race, or whatever the topic may be. So again, not just kind of stopping at the description, but going into some of the history. And then finally, representing the spectrum So for example, a lecture on common pediatric rashes or whatever your field or topic may be can include images of children of different races. And we have, towards the end of our slides, some additional resources that may be helpful for that. And then finally, we can also disrupt bias on a systemic level. And I think the role here kind of depends on where this is happening. So these interpersonal comments or actions, I want you to think back to kind of disrupting in the moment. But when we are, or when you are on a committee that's thinking about new policies in your institution, or how do we make decisions around who gets funding for research? This is where thinking about this disrupt model comes into play. I really want to give a lot of acknowledgement to Dr. Miranda Ward at GW. She was the real inspiration behind this disrupt model that she and I have worked on training. We want to introduce that model here. So on the systemic level, so disrupt being an acronym. The D being determine if the decision or statement maintains whiteness. I should pause and say that this is specific to disrupting racial bias on a systemic level. And the focus here around maintaining whiteness is I wanted to, it's a term that I think is becoming more familiar, but is still often, I think, misunderstood. So just kind of backing up and defining what whiteness is. You may hear those terms, whiteness, blackness. This is not specific to individual people, but rather to what is considered standard or norm. So defined as the way that white people, their customs, culture, and beliefs operate as a standard by which all other groups are compared. And the asterisks here, of course, this can be extrapolated to other majority identities. So not just to race, but you can also think about how based on gender or age or socioeconomic status, that there are certain groups that are considered the standard by which other groups are compared. So specific examples, both personal and in the literature, when you think about Band-Aids, for decades, when you walk into the grocery store or to the drugstore, you buy a box of Band-Aids. Typically they're one color, sort of a light tan color. I was well into probably my 20s before I realized that Band-Aids were meant to blend into skin and not to stand out. They never blended into my skin. It's only been in the last couple of years that you're more likely to see a range of colors, range of skin tones for Band-Aids. So again, with that sort of light tan color being the norm. Another example, I had knee surgery a couple of years ago, and after surgery, kind of looking online for bandages to sort of wear to as my knee was healing, going to physical therapy, and looking for knee braces. I found several online that were the same color as the Band-Aids that you see here, sort of a light tan color. And those colors on the websites were named skin or nude, which again, if you think sort of globally, most people don't have a skin tone or a nude tone that is a light tan. There's a wide variety. So thinking again about how this is when you say, sort of the focus on whiteness is the core or the standard by which other groups are compared. There's also literature, just that second image there, that have shown in different studies that people who have names that are assumed to be white are more likely to get an interview based on their resume compared to the exact same resume with the name that is assumed not to be white. Also, there are studies looking at clothing styles, and those that are considered to be more Western or more white are considered to be more professional, and others that may be appropriate based on a certain person's culture or customs, considered non-professional. So again, that's what we want to disrupt, just this idea that skin tone or again, other demographics should be the norm by which others are compared to. We also want to make sure that we are considering the impact, not the intent, as Dr. Escalante mentioned. And then when we're working on a systemic level, also state the threat that this issue or statement is causing to the institution's commitment to justice, equity, diversity, and inclusion. I think more and more institutions have diversity statements now. Use that as part of your armor when it comes to disrupting biases. The R and the U kind of go from focusing on that systemic level to now, what is my role in this? So reflect upon your own personal identity. What are you bringing to the table? We all have biases. Are you looking at the situation from a certain lens? and understanding the risk. So for some, there may be more risk or less risk when it comes to speaking out around biases and microaggressions. And then the P and the T kind of take us forward into movement. So first, notice how power and privilege operate. If you are in a position of power or privilege in this committee or in your institution, or just based on your background, you may actually have more responsibility to be able to speak up, as it's less of a risk for you. And then taking action can look different depending on the different situation. And maybe thinking about how we shift around the power, or maybe thinking about how we determine what the norms are. But the thought is to kind of go through these self-reflection steps before kind of taking action and making decisions on different policies in our institutions. So that was a whole lot of information that we shared with you. We wanted to now bring on the panel to kind of discuss a case that we have. So we have Dr. Escalante, Dr. Knight, Dr. O'Donoghue, and Dr. Leovonte Raphael, who were introduced earlier. Really esteemed panel. I know Dr. Escalante and I are really thrilled to have you all here. What we wanted to do, and Laura or Dr. Hahn, pause me if I need to pause for Q&A now, or if we'll
you keep going.
later. Okay, great, thank you. So we do have a case, and we thought with some of the experts that we have, it would be great for us to present the case, but then have our panel of experts kind of discuss how they would approach this, thinking that this could be helpful for you all in the audience to kind of, hear kind of the sort of the back and forth. At any time, if you have questions, I think you can put them into the Q&A, and we will address those towards the end. And I would ask to, in terms of time, please let us know when we're running short on time. So here's our case. A resident asks you to observe her with a patient and complete a structured clinical observation form, so just an assessment of the patient's bedside skills. You walk into the patient room together. The resident introduces herself to the 12-year-old patient and the patient's parent, and the parent responds, "Oh, that name is different. I'll never get that right. I'll call you Dr. P." The resident pauses, furrows her brow, and says hesitantly, "Oh, okay." Then begins to ask the HPI questions. So you're the attending, working with the resident, and you're there in the room observing all of this. I'm sure you're all ready to jump in to talk about what you would do in this situation. But before we talk about sort of our action here, let's pause and just kind of, I'm throwing this out to all four of you. Kind of where do you see there being a microaggression here? What role might implicit bias be playing? So what are your thoughts on kind of what's going on?
And I'll ask the panelists to go ahead and unmute yourself to speak.
Dr. Knight, I see you unmuted.
Yes, hi. So whenever a name is different or unusual to individuals, I think sometimes there's some othering that occurs with those names, because there are names that are unusual that lots of people learn how to say. So that in itself is an othering type of statement, to say that your name is not similar to names that I've heard in my personal experience. So to me, that in itself is sort of the microaggression, that I'm not even willing to try to get to know your name or how to say it. It's kind of not a priority to me.
I would also piggyback off that. Just when you say your name is different, you're almost alienating the person from the country they're living in, and saying they're somehow different. But I agree, just like you said, you can learn how to say somebody's name, or just pause and say, I would love to know, how you pronounce your name, because I want to get it right, and just give the person that time and respect for their own name.
I definitely agree with those. By calling the person Dr. P, it was sort of an insult because the person wasn't willing to learn. I think the doctor could probably in turn say, well, let me help you to pronounce my name, you know, give them a little bit of information. It's a two-way conversation. One has to want to learn and the other has to be willing to say, you know what, let me help you with my name. That's important because you're basically insulting someone when you don't want to call them by their name, unless they give you permission to say my name. You can just call me Dr. P.
And the only thing I'll add to that, I think, is, you know, thinking a little bit about what bias is, and, you know, based off of, you know, what Dr. Knight was talking about with othering, you know, the bias is the fact that, you know, some groups are allowed to have their full name said and other people are not. And so, you know, really taking a look at what the bias is so that we can understand who is being centered in the conversation.
Great, thank you all. So I think, you know, you're hearing a lot around othering and alienating, kind of, again, thinking about what is the parent think is the standard for our name, right? And what are they comparing this resident's name against? So, you know, before you decide on what you're going to say, you know, first you have to decide when and where to respond or to speak up. What do you think are some of the pros and cons of, say, responding immediately in the room or later on just to the resident separately, or just with you and the parent? You know, what are some of the potential situations or pros and cons there in terms of when and where, and how would you make that decision?
This is Donna. I would say that was a time to, you look at it as a teaching moment, both to the resident and to the parent. I mean, you know, you're not there to insult, you're basically there to clear up. So you're teaching the resident that this is how you would handle it in this particular situation. And also the parent, and my name is, and, you know, give them the permission to call you by something other than your actual name. I think that's a teaching moment, and it should happen at the very beginning.
Yeah, I think this is a hard one, only because, you know, I have the like instinct to want to call out in the beginning, but I know that by doing that, it could also potentially derail the residents' ability to get their job done and do it in a way that would allow me to evaluate them at the best of their capacity in that time. And so, you know, sometimes I will wait until it is my turn to speak so that the resident can get through their assessment, because if I sort of insert, you know, that teachable moment right then, it could impact the resident's performance. I think that there is a lot of benefit actually to doing it early. Sometimes I will, depending on what is going on in the room, I might change my approach on that, but I might be more inclined to wait.
Yeah, I do agree there's some nuance to this situation. In an attending role, I tend to be fiercely more protective of my trainees. And so I'm more inclined to redirect in the moment. But there is, you know, that hierarchy with your trainees, and sometimes putting them on the spot are making a uncomfortable situation more visible, makes it awkward for them and their future interactions. So I think there's a balance of trying to figure out when is the most opportune time to step in a way that preserves the therapeutic relationship between the resident and the patient and family.
Yeah, I agree also. I think there's definitely a balance to be looked at. And again, it goes back to the variables in the room at that time, whether it's a safe environment to do it or not, or that you might take away some responsibilities or power to the actual student or the resident in the room at that moment. But I would again feel very protective if it was my student, and I might use some of the wonderful things that you talked about, Dr. Falsey. For example, that teachable moment of saying intent and impact, to the parent, and especially because the parent has a kid in the room as well. And it's not one generational, it's the next generation as well that's getting affected in that room and hearing what their parent is saying.
So you each kind of talked a little bit about the different roles in the room. How do you think power and privilege kind of come into play? How do you think about that when it comes to, Dr. Knight, you said you like to protect your trainees. So how do you think about that role in this sort of situation when it's your trainee who is the recipient or the target of a microaggression?
I think sometimes trainees, knowing their role on a team, don't feel as if they're in a position of privilege and power. And I guess that's where empathy comes in, because I've been there. And so sometimes it's hard to know when it's appropriate to speak up. There's fear of repercussions or assumptions or biases being made as the trainee if you are interrupting bias or speaking up for yourself. And so I think in general, and this is a generalization or bias of mine, I think sometimes trainees are a little bit more hesitant to advocate in these situations for fear of being labeled or having an adverse outcome or having a patient or family complain. And so I know that because of where I am in my role on the team, that I don't worry as much about those biases. I know that people know me and they respect me, and so they are less likely to label me if I were to speak up, and I'm less likely to face those same repercussions. So I guess I think about those things with respect to trainees and reflect on a lot of my experiences. And as was mentioned before, I think modeling is very important. So teaching individuals how to approach these situations, because they will continue to happen even as an attendee.
And just to add to that, I would say in terms of the modeling, I feel like it's really important that both the educator, the student, the parent, the young child should be able to have the opportunity to work in a psychologically safe environment. That means that, when you do better, the other person knows, and then they learn, they'll do better. But it sort of still takes the time to be able to open that door to make sure that everyone knows it's a teachable moment. It's learning. It's not there to, put someone in a corner and say, hey, you shouldn't have done that. But it's just making sure that you provide a psychologically safe environment for all.
Yeah, I think that's an excellent point. And we ask these questions, but knowing that there's no one right answer, right? Depending on the situation, it might be best to speak up right then, or it might be best to kind of wait and talk to the residents separately. You each started talking a little bit about what you would say. So let's get even more granular. I think when we've done these kinds of trainings in the past, people always want to know, like, so what exactly should I say? If I'm there in the moment, it's easy to get tongue-tied, and then an hour later, it's like, oh, I should have said, X, Y, Z. So what kind of give people some practice? Like, what would you say? So whether you're saying it right there in the room or to the resident later, can you give people some guidance on how you would approach this and what you would say to the resident or to the parent?
I'll take a stab at this one first. I think this is the hard part. So thank you, Dr. Feluci, for making it difficult. I always lead by example. And what I usually will do is when it's my turn to speak, I will continue to use the resident's name as Dr. Whatever the last name of that resident is, and continue to do it over and over again. One, out of repetition so that the patient and family hears it. But then two, it gives me a reason to circle back later, like when we're sort of in the middle of it. I like to use comedy because I think I'm a funny person, and I always tell people to like use your personality, whatever works best for you. And I find that because people usually laugh at my jokes, like I'm able to sort of use comedy as a way to be like, okay, well now, you've heard me say, Dr. P's name over and over again, and look at the patient and say, hey, do you think you can say it? And say it back to me. And then what I always do is I actually use one of the methods that you mentioned, which is that in the past, people have not been able to say my name. And when that has happened to me, it has made me feel really sad. And so I'm hopeful that by the time that Dr. P, comes back later on today to check in on you, that you're able to use her name, because it is important that, all of us on this team caring for you feel like that, while we are caring for you, that you also care about us and our feelings. And sort of starting with comedy and then ending with like the actual teachable moment. I've found like a lot of parents will say, oh, I'm sorry, which is really appreciative, but then in my head, I'm like, I still want you to do it. And then the resident, I think also by the same token, you are modeling for the resident how to deal with that in the future, because, this is a scenario in time, but this has happened to this resident before. And for people who have names that are difficult to pronounce, we have to deal with this constantly and eventually sort of learn our own language for dealing with it for ourselves so that we can hopefully model that for our training as well.
Yeah,
Thank you.
I also like the idea of using humor, especially with a name that's hard to pronounce. And I love the idea as well to empathize with the student or with the resident and give them a validity that, yes, I noticed that you hesitated and that you paused for a moment. So clearly the resident was affected at that time. So we know that from the script. And to really just give them an opportunity to speak, how did they felt about it? And then what can we do to, if this happens again? I also love your suggestion of the practice beforehand, that before this ever comes up, like that we should have training somewhere as a mainstay from the very beginning, that look, in the moment, we're all like, did that really happen? Did they really say that? We're all like blinded in the moment. But if we have, I suppose, some kind of pre-training and understand intent from impact, I think that would be a great way just to, I suppose, begin the conversation and understand that, I suppose, to educate and teach within the moment. For the parent part, I think as well, I suppose it would be important to have a conversation with them, because as a person and also as a person who, I suppose, is saying this in front of their child, so that there's a double education happening there as well.
I think it would be also important to open a dialogue to learn more about the patient's perspective. Why do they think it's okay to actually call the person Dr. P? I would also, take the resident and debrief them afterwards, just to see what they've learned, how they felt. I mean, the situation is a little bit uncomfortable. It is a patient encounter, and it's something that's important for that trainee at the time to reflect and be able to debrief in some sort of real time, to be able to ask questions like, if the situation happens again, how do I handle it? Or do I take it that seriously? Or did the person really have an intention to hurt? Or, just, ask questions and see what the answers are and then go from there. I think it's important.
I also think it depends on my relationship with the patient and family. If the relationship is not there and it's a newer relationship, I definitely defer to humor. I will make up a word that rhymes with the name, or say, if you could say X person's name, which is super hard, I have faith that you can say Dr. P's name as well. If we don't have that relationship, if we do have that relationship, I'd probably err on being more direct with the family and say, oh, but their name is Dr. So-and-so, not Dr. P. The flip side of this, we talked a little bit about interrupting in the moment versus speaking later. If I would want to debrief with the resident whether we interrupted in the moment or did not, since there was a hesitation and pause. And I think that's the other piece of this, is sometimes this is, not the fight that that particular person wants to have. And so being sensitive to what they want in the situation is always a little tricky, just to make sure that we're not putting them on the spot or making them uncomfortable. So depending on who the resident is and maybe my experience with them previously, I might even consider having this conversation separately with the parent, so that the resident is external to this interaction and they are not coupled with this, and there's not that conflict with the resident present if they're, if the resident will continue to interact with this family in the future. So I think those are the things that make microaggressions hard, because you have to weigh all of those things in the moment and make a decision pretty quickly as to what do you think this resident will want and what's best in this situation.
I think that's a great point. I think as faculty, in our position of relative power, when it comes to working with trainees, we may want to jump in and make the situation better. But sometimes for the trainee, maybe they don't want attention put on that. And debriefing with them after, or talking with them first before you talk to the family, in some situations may be the right thing to do. Particularly if it's an inpatient and you'll be kind of going in and out all day. If they're in a primary care setting like I am, I might be more pulled to say something right there, kind of knowing that this is the beginning and end of that relationship for the resident. But it really just depends on, as you all said, your relationship with that family and maybe even with the trainee as well. I think we are at a point where we can turn it over for audience questions, if there are any.
Yeah, Andrea, did we have any panel questions from the audience?
Yes, so there was one question that I think we just discussed, which was when you're using the information that you have to make that decision whether to intervene in the moment or to speak with a resident outside, do you run a risk of maybe by making that assumption that the resident wants you to speak in the moment, perpetrating another microaggression by not allowing them to have their own kind of independence in that? So I think you guys just spoke about that. I do have a question if we're going to move over to the Q&A portion. So back to the point about kind of power. If Dr. Feluci or Dr. Escalante, the panelists as well, if you guys want to answer this question. But kind of at what level do you, recognizing that there may be a hierarchy in your role with a trainee, to kind of take it up the chain? So is it are there certain situations where you would recommend that if you witness a microaggression, if it reaches a certain level that you need to kind of, regardless of the person who it happened to, take it up and kind of escalate it versus just kind of having a conversation with the resident to empower them to handle future situations, but not necessarily escalate it further?
I think for me, this is where we get into how important it is to also address this on a systemic level. And in this situation, It probably depends on what the response is from the parent as to whether or not it gets escalated. If it's a difficult interaction, then I think escalating, not to change the parent's mind or parent's behavior, but escalating rather to think about how are we messaging to patients and families about people's names and identities, right? Or what are we doing to train our residents around when these things happen, how they can maybe speak up for themselves, or are we being proactive in providing support for those who we know will experience being othered during training? Now, are there supports already in place for that? So I think once you get through the shock and awe of it happening in the moment, I do think that bringing these issues up the chain around preventing or at least having supports in place to mitigate the impact is really important.
Yes, and just to amplify what you said, Dr. Feluci, thinking about the chain that you want to go up, because many of us are pediatricians, and so we operate within a hospital system, as well as operating within a GME or residency or school of medicine type system. And so thinking about, is this an issue for the hospital that requires, we have, patient agreements, or requires leadership from the hospital to actually come in and intervene and set expectations and rules for interactions, maybe a reminder discussion that this is a training institution and we do expect that you are respectful to whoever may be seeing your child, versus is this kind of an ongoing, as we mentioned, kind of an ongoing death by little cut situation in which we worry about the individual's well-being, and we want to make sure that their training program is aware and is providing those supports, as you said. So I kind of think of, does it need to go up both chains, or does it need to go up one in particular? But yes, I think the short answer is yes, there are definitely situations that require more intervention.
I had a question for the panelists. I'm Jay Patrick Nanny. I don't know many of you guys personally, but thank you for all the information you've given us so far. I've seen many of my female colleagues get, you see subtle sort of microaggression around gender and, male physician, and, unfortunately, maybe generally older male physicians who sort of quote unquote grew up in a different culture. I bring that up because I've heard female colleagues sort of use as a, they don't mean it, this is just what they know. That's those sort of comments. And after seeing a microaggression towards other fellow faculty, I've sort of said to them a couple of times, you don't have to deal with that from that person, or there's ways to escalate this. And again, I sort of hear that. Sometimes I hear that's just what they know. They don't mean it. They're not trying to be mean. And it sort of never goes anywhere. And you see the same person sort of doing it to lots of different people. What's sort of as a disruptor, if people don't want you to disrupt the situation, despite asking, well, how many times can you possibly say the same thing over and over before now you're making it 100 times worse for them, which is already an uncomfortable situation?
This is where my desire to implement comes in, because I think that then we're really talking about structural racism, right? So from my perspective, I always tell people words mean things, and because words mean things, we need to think about them before we speak. I as somebody that has seen my female colleagues in this position, what I typically will do is, because I have a big mouth, is I will stand up for them. And it sort of depends on sort of what the interaction is. If it is amongst providers, I tend to be a lot more forceful. If it is provider patient, that's a little bit different. And in that sense, I tell people, if you recognize what privilege you have, then you can leverage that privilege in order to lift while you climb. And from my perspective, I think that if I'm noticing the same thing happening over and over again, then I'm that's a structural issue. And so how do we create a system that supports everybody that's in it. So for example, one of the things we're talking about is like, what chain does it go up, right? I work in an outpatient setting as well. And so it is important to me that the people at the front desk know how to say my name. It is important to me that they say Dr. Escalante. It is important that they pronounce it correctly. And that repetition matters. And then when something happens, like I'm the medical director of the teen health clinic, and my female colleagues, this happens all the time. We take care of very complex issues that require trust with the medical provider and the patient and the family, like eating disorders, gender care. And if I notice that as a medical director that one of my female colleagues is having negative interactions based off of implicit bias, then I will use my words around the conversation of implicit bias, because it is important that we all understand what that means in a way that, you know, isn't to put people off, but is a way to educate about we are all medical providers and deserve dignity and respect as people.
Yeah, that's some great advice. I always worry about the impact versus intent thing, because you're intending to help that person and to do something good for them, especially if it's a repeat perpetrator, but then the impact on that person who it happened to could be negative, because the person who is getting, you know, not disciplined, or whoever's getting being asked to correct their behavior may blame that person, and then I'm not even involved, you know. So thank you for that advice. I think it's really good.
And I just want to reframe the perspective too, just continuing with what Dr. Asante said about using your male privilege. It seems like the microaggressions actually bother you as well. And so it doesn't have to be escalated as an issue for your colleague. You can say, I've noticed this and it's affecting my workspace. I feel, you know, whatever your words are or whatever emotion you have, seeing these interactions and the toll that it takes on you can be utilized to address the issue and keep it external from your female colleagues where, you know, that impact may occur as well.
Yeah, I agree with everything being said as well. But even just in the moment, sometimes I've seen microaggressions when we're talking about male, female, where females might be constantly interrupted in the moment, and you don't have to call it out. You could just support. That was a wonderful thing that you said, Dr. Knight. Let me hear more. You know, so it doesn't have to be called out at that time if it's not in a safe environment to do so, and you can talk maybe personally to the person in the background, but just supporting your colleague, male or female, if that happens in the moment, I think is helpful.
Did any of the other panelists have any more comments to make? If not, then in the interest of time, I'm going to bring this to a close. I just want to thank all of you, both Dr. Escalante and Dr. Feluci, for an amazing session. Really, we have such amazing tools to use and such awareness of things. And I really think it's important for us to escalate this to our systems and make the administrators aware of this and actually inform them of these tools that they have available and help them to recognize where they might not even know that the impact they're having. So thank you so much. I also want to thank the panelists for your willingness to participate so open and make this a safe space for others to hear your wisdom. And so I would also like to thank anybody who participated in the Q&A. Thank you for that. I also would especially like to thank Andrea Hahn, AFMR Eastern's own chair-elect, for organizing this. Really such an amazing session. We'd like to finish again by thanking our sponsors, and in this case, it's AFMR. Without the support, this conference would not be possible. And we hope you'll stick around for the rest of the meeting. One highlight is tomorrow's plenary session 2 at noon, the ESPR Mentor of the Year presentation titled The Challenge of Communicating Science During COVID by Paul Offit. Thank you so much, everybody.